Hi, a very good evening to all of you. This is Dr. Vivek Goyal, and I am back with you with nephrology class, day 5. We have had a very good journey so far. We have learned so much about nephrology in the last 4 classes. We've dealt with basics. We've dealt with how to investigate the disease. We've dealt with how does nephrological diseases present to a physician. We've seen how glomerular diseases present to you. So we've seen a lot of things. And yesterday we have completed glomerular disease and a very important. We have done 3 very important congenital diseases. Am I correct? Yeah. And due to some untoward and unforeseen circumstances, our class came to a halt yesterday, because there was. I'm really thankful to all of you. You all have shown me a lot of support. You all texted me personally. You all mailed me. You all tagged me on Facebook, showing so much solidarity with me and so much of love. And I'm really sorry if I let anyone down. My actually intent was nothing like that, and I wasn't angry at all. Maybe a 1 or 2% of hurt was there, because it said that the persons whom you love the most only you get hurt by. So maybe it was there, but chalo, never mind. It's done now. It's done, and we are again with you back. And I'm again there with a very broad smile, and we shall be studying nephrology with the same zest, with the same gusto, with the same excitement. Yes, motivation coming up very soon, students, and we shall be dealing with the next thing. And I all love you. And if anything was left, I shall complete it today also. And one message was pretty clear to me, that yes, my main motive shall be covering as much topics and imparting as much knowledge as I can to all of you. And irrespective, because time is a very byproduct and a secondary thing. I never look at the watch when I study, nor do I look it when I teach, because time does not time, it has to be time bound, definitely. Study has to be smart, but when you are engrossed so much in it, it hardly matters. And today it shall be the same, as most of you have conveyed it to me yesterday through mails and messages and lot many things. So thank you very much. And some people got apprehensive that sir has got angry or sir will not teach. For those, let me tell you, I'm just like an elder brother. So भाई आया है तो पढ़ा के ही जाएगा. I will not let anything come between the both of us. So if your elder brother is here, definitely I will teach you, and I will teach you as much medicine and nephrology as I can in the few numbered days that I have got from my team. Okay? So do not worry anything, and I am there with all of you, always, for anything that you need, and for any service I can be of to you. Okay? So, beginning with the very mandatory, how's the Josh? Very high, sir. How's the Josh? Sky high, sir. How's the Josh? Unbeatable, sir. Unbeatable, sir. Okay? And if one has to motivate oneself or the other, I really consider this person my idol, Mr. Muhammad Ali. Mr. Muhammad Ali, though I do not have anything to do with boxing, but if the question of commitment, if the question of persistence and hard work comes, I think he is the epitome of it. He is the epitome of it, and he said a wonderful statement, which I have tied a knot with myself and kept it with myself, that if your dreams don't scare you, they are not big enough. And you know what? I have kept this quote and this poster on my study table. Because whenever I dream something, whenever I want to do something, I just look at it and think, is it scary enough? Is it scary enough? So right now, most of you are dreaming, please God, give me a PG seat. Is getting a PG seat scary enough? Some people would be like, sir, please give me a PG seat in medicine. Is that scary enough? Some people would be like, sir, please give me a PG seat in so and so college. Is it that scary enough? If you would be like, sir, I want a PG seat with medicine with rank 1 in AIMS and with rank 1 in next PG, that could be a bit scary. But are you really afraid to even dream that way? Leave doing. At least dare to dream. So, whenever you think or aspire to do anything, please and please think, is it scary enough? And if it is scary enough, if the world laughs at your dreams, मान लेना तुम सही रास्ते निकले हो. मान लेना you are on the right path. Okay? And of course, the very famous saying and the very famous, story of Muhammad Ali, that, one day he was seen practicing in a ring. And, he was on a live match. And, while he was fighting, he kept on saying, I am the best, I am the best, I am the best, I am the best. The referee was like, pagal hai kya? Is he lunatic or what? Is his frontal lobe dysfunction or what? While fighting, he's losing and he's saying, I am the best, I am the best, I am the best. Then he said, to be a great champion, you must believe that you are the best. Even if you are not, pretend you are. If you want the world to believe something, you first have to believe that thing very, very firmly. So if you ever aspire to be the best in the world, the first and foremost is, you have to believe that you are the best. And sometimes, sometimes you might not be actually, but those are the times you have to, deceive your heart, you have to deceive your mind smartly enough and tell yourself that I am the best. And by saying that I am the best, I am the best, I am the best, Muhammad Ali's opponents used to get really scared of him. And ultimately, he used to win them over in the mind. And victory in the mind is the first step towards actual victory. So, he used to beat them off the ring. And once a person is beaten in the mind, no matter how much he knows, how much strength he has, he will ultimately beat you. Is it clear? Is it clear? That's the way. But you have to work hard to believe that you are the best. Alright. So, let's begin with today's class, and I shall definitely begin by continuing from wherever I had left. Last, I remember, I had taught you the different glomerular diseases, and I had taught you the congenital diseases. Now, let me show you a few photographs which I couldn't yesterday, and let me begin with a patient of mine which I saw in my third year residency, and this patient was a 20-year-old male. He was a smoker, and he came to me with shortness of breath, cough, and there was blood in his cough. When I got the X-ray done, you can see there are parahilar ill-defined shadows here. Parahilar ill-defined alveolar opacities. Can you see that? So I definitely knew he's coughing out blood and he has such shadows in the X-ray. Definitely there is an evidence of diffuse alveolar hemorrhage. Next, the very next day, he said, sir, I am peeing something cola colored. And when I got the urine examination done, it had casts. And when we got the biopsy done, later on, of course, it had linear ribbon-like IgG deposition over the glomerular basement membrane. And you are absolutely correct. This person also had the antibody against the NC1 domain of alpha-3 chain of collagen 4, and this patient was good Pasteur, not syndrome, but disease. I hope I am absolutely clear to you. And of course you are correct. We gave him methylprednisolone and cyclophosphamide and also plasma exchange. Clear? Very good. Now, beautiful. Now, this patient was a 23-year-old male. 23-year-old male, and he came to us with polyuria. He came to us with polyuria. There was a bit of proteinuria also, and his urine had oval fat bodies, and on top of that his eyes had vertical opacities. Can you see the vertical opacities? Yes, these were the corneal verticillata, which is an MCQ point. And his skin had, you can see, vascular tumors of the skin, which is known as angiokeratoma. Sir, what is angiokeratoma? I told you, it's everything is there in the name. Angio means blood vessels, kera means skin, oma means tumor. So it's a vascular tumor of the skin. Is it clear? And just remember, whichever exam you sit for in future, now, whichever Indian, foreign, these two are keywords. Anywhere if you find angiokeratoma, mind mein, your medial temporal lobe should prompt you, sir, you are being asked Fabry's disease. Clear? And I told you, Fabry's disease has oval fat droplets and they have a Maltese cross appearance in the urine. They have a Maltese cross appearance like any lipiduria. And I told you yesterday that in their biopsy, you have two important MCQ points. One is myelin figures and one is zebra bodies. Sir, what are they? The sphingolipids are deposited in the cytoplasmic vacuoles in the visceral epithelium, and they are arranged parallelly. In concentric whorls. Can you see this? That is why individually they are known as myelin figures, and the pattern is known as zebra bodies. Both of them are MCQ points. Is it clear? Now, very important diagram. Just see, this is your normal filtration barrier. This is your endothelium, this is your GBM, and this is your food process of podocyte. So this is the normal thickness of your glomerular basement membrane. But just see, here the GBM has been reduced diffusely to a very thin structure. And when the GBM thickness is diffusely thin by less than 250 nanometers, and the patient has a familial predisposition, autosomal dominant inheritance, and only hematuria, but excellent prognosis, no treatment required, that is known as thin basement membrane disease, or TBMD. Whereas here on the right, I told you two mothers had come to my OPD. The second mother, which had come with a lot of pain in her heart, because she said, sir, मेरे बच्चे को ना केवल हेमाचूरिया है, my son not only has hematuria, sir, he also has eye में problems, कान में problem, mental retardation, sir, lot of problems, sir, and that is Alport syndrome. And you can see the GBM is abnormally lamellated, thinned out, and that has a basket weave appearance. And please do not ask me the details, why weave, why basket. Please ask your pathology teacher. Okay. I have been receiving such queries. You people are asking me the logic behind facts also. So you will be asked me, sir, why does the sun rise in the east and set in the west? I am getting queries literally related to this also. But never mind. I only am reminded of a famous saying of my mentor. You know, my mentor used to tell me, Vivek, a great teacher or a very good teacher is not he who answers all the questions. In fact, it is a myth that a person can know everything. Not at all. If a person is just a storehouse of information, he is not a very good teacher. A very good teacher is he who can incite or instigate the fire of questioning inside a person. So if I have been able to incite or instigate a feeling as to why behind everything, a feeling as to knowing more and more about patients, I think I have been a bit bit successful, if not a lot. Okay. Okay. And now, the second last topic of the day that I taught you yesterday. The second last topic I taught you yesterday. I told you that I taught you C3 glomerulopathy, जिसके disease, जिसका hero was only C3, complement C3, due to excess alternate complement pathway activation. And I taught you it has two types. One is dense deposit disease. One is C3 glomerulonephritis. Dense deposit disease had two associations. One was lipoproteinaceous deposits in the retina, which was known as optic drusen. And if you can notice here, this person has lost adipose tissue from the face and from the deltoid, and this is known as partial lipodystrophy. And I can bet over this that this year C3 glomerulopathy is going to be asked in one or more of the exam, and you know these two are very important MCQ points. This has never been asked yet. Is it clear? Absolutely clear? Good. And now let us begin today's agenda. By starting acute kidney injury. The next chapter that we shall be studying today is acute kidney injury. So now let's take a fresh page. And begin acute kidney injury. Okay? Or if you want me to discuss the question answers of yesterday also, I can do that. So let me do that first. Now, this question was asked in AIIMS May 2015. Where the question was most common type of nephropathy associated with malignancy. Now, if you can just recall my table, IgA was not associated with any malignancy, FSGS was associated with non-Hodgkin's lymphoma, minimal change with Hodgkin's lymphoma, and membranous with two above diaphragm, breast and lung, below diaphragm, colon, kidney. Out of the given options, so MPGN is not here. Out of the given options, which is the correct answer? Sir, those without saying, sir. I know everybody of you have my table in front of your eyes. I know that. You are thinking, sir, left में Hodgkin's, beach में non-Hodgkin's, right में 4. I am correct? If I am correct, give me a smiley. Answer is membranous. Good. Wow. PGI Chandigarh, I told you, if you are planning to crack PGI Chandigarh, RTA is one chapter you cannot afford to leave, because every year one question will come from RTA, and it is slightly on the more difficult side for others, but my students, my younger brothers and sisters will not have any problem, because you know you have the master table with you, and if you have it, nobody can stop you on this earth. Proximal RTA is associated with, if you remember, proximal artery का mnemonic was VAMP, MP. Come on, recall with me. Wilson's, amyloid, myeloma, PNH, metabolic disease, lead poisoning. Remember? Now, SLE. Sir, SLE में तो 1 होता है. SALSA. Not this. Sjogren syndrome. Sir, that is also 1, sir. And if you know, proximal artery is basically type 2. I am basically discussing type 2. Lead poisoning, yes sir, correct. Multiple myeloma, yes sir, correct. Fanconi's anemia, yes sir, correct. Oh. Most of you I know made this mistake. Why sir? Sir, please read the thing. It is Fanconi's anemia. Not Fanconi's syndrome. So, the difference between Fanconi's anemia and Fanconi's syndrome is equal to the difference between right now between you and your PG seat. That much difference is it. So, this was basically a trick question. Most of you would have fallen in the pit. And you know, it's the examiner's psyche. I'm telling you, it's a secret. Whenever a teacher wants you to fall for an option, he wants कि तुम्हें गलती करो, he will always keep it as option A. Trust me. So C, option A was Fanconi's anemia, and this is wrong. Sir, Fanconi anemia is not associated. Had it been Fanconi syndrome, it would have been. So answer is B and C. B and C. If you made a mistake, admit it. Give me a thumbs up and admit that you made a mistake. If you admit it, you will basically know that you are not going to admit it again. Good. That's the spirit. That's the spirit. Good. So answer is B and C. Super. Now, I told you this question is just 7-8 months old. And you know, trust me, when this question came in the AIMS exam, November exam, I was flooded with messages in my messenger inbox. Why? Because students told me, sir, when you were teaching, you were thinking it's very difficult, sir. Why will it come, sir? But it actually came in the exam. The question was, pulmonary renal syndrome includes what? I told you, pulmonary renal syndrome has number 1 autoimmune cause, number 2 infections, number 3 drugs, and number 4 miscellaneous, which had fluid overload. Very good. So good Pasteur syndrome, yes sir, it will have RPGR and DH, correct sir. Leptospirosis was there in the infection. Hantavirus was there in the infection. Vaginous granulomatosis, obviously sir. Srinath sir has taught us so nice sir. Answer is all 4 are correct. Answer is all 4 are correct. So ready to crack games? Yo, that's the spirit. That's the spirit. Now, let's see. First you answer this, then I will tell you where this question was asked. Acha, this was also in AIMS November 2019. I'm so sorry. 12-year-old boy, history of deafness and hematuria with CKD. Deafness, hematuria. Mother, 2 mothers, second mother or first mother? First mother only had hematuria. She did not have ear problem, so probably second mother. Family history, maternal uncle. Maternal uncle, inheritance, X-linked recessive. X-linked. It is X-linked recessive or X-linked. Now, kidney biopsy was formed which show a normal light microscopy. Can be normal because it is basically it is seen in the electron microscopic finding. Correct? Answer is not thin basement membrane disease. Answer is Alpors. Good Pasteur और PSGN का तो सवाल ही नहीं उठता. The 2 DDs were Alpors or thin basement, but thin basement membrane में there will never be deafness. No deafness. Clear? Good. You are absolutely on the correct track. Now, leave this. Now. First to answer this question, then I will tell you where did this question appear. See, in the next also you are likely to get long clinical questions. See, I'll tell you the keywords. 26-year-old woman came with non-visible hematuria. So microscopic hematuria. Now, she had no visible hematuria, dysuria, nothing. Sisters also had the same problem. Sister had the same problem. So, family member involved. Examination, BP normal. Next, serum creatinine normal. So, no hypertension, no renal failure. Proteinuria normal, no proteinuria. Serum complement normal, dysmorphic cast. So, basically, it's a cause of glomerular hematuria which is running in families, because multiple family member involved, but no extra renal symptoms. Now just see, you know the answer. First mother or second mother, tell me quickly. It is first mother. No deafness written here, no hearing loss written here, no retardation written here, no X-linked inheritance shown here, nothing that. So you know, the answer is thin basement membrane disease, and it is an inherent disorder which involves the 3rd, 4th chain of collagen 4. Now just see, they didn't ask you straight the diagnosis, they asked you the defect. So basically, you have to know the holistic view of the question and the answer. Such a conceptual question. And you know where have I picked this up from? This question was asked in USMLE exam. So I'm just showing you the pattern of different. They could have easily asked you the defect in thin basement membrane disease lies in. Answer what? But that would have been rectifying, mugging up. But because you are my students, you can visualize patients. Because we are not studying dead subjects like anatomy and biochemistry. No, not at all. We are studying clinical medicine. And the charm of medicine is that you must be, whatever we are doing, teaching, learning, whatever, ultimately it is for what? Seeing patients. So if you cannot see a patient by my teaching, then my teaching absolutely is of no use. So this is the answer. Is it clear? Now let's see. This is my question which when I appeared in one of the exam. Let me tell you which exam is this. This was asked in MRCP Part 2. Exam does not matter. It is a topic that matters. But I'm just showing you what. 27-year-old male, polyuria, polydipsia. So basically, the patient is not being able to concentrate urine. He is having a concentration defect. Because normally what? You take out the water from the urine. But I told you one disease, the most early presentation of this is concentration defect. He experienced pain in the feet. Oh my God. Pain in the feet without injury. Pain without injury. It is a type of autonomic neuropathy. What else, sir? Sir, what else? He had abdominal telangiectasia. Sir, ab to kuch bacha hi nahi, sir. You have taught us. You have taught us one thing, sir. Abdomen, some telangiectasia or vascular lesions. Vascular lesions, neuropathy, concentration defect, and sir, you have shown us proteinuria and raised creatinine. I know the answer, sir. I know the answer. Answer is Fabry's disease. But sir, they have not asked the diagnosis. They are such crooked people. What they have asked is the biopsy of Fabry's. And I taught you a keyword. Whenever the biopsy will be asked, two words will be there. Either zebra or myelin. See the answer? Myelin bodies. Answer is 2. Isn't it beautiful? Isn't it beautiful? Are you happy learning? Are questions approaching not become easy? Yes or no? Yes or no? Give me a love wala smiley. Quickly, give me a love wala smiley. I know that you have enjoyed. This is the way. This is the way. Okay. Superb. So students are really enjoying. This is the way if you attach clinical correlation to what you study. देखो Fabry's तो पढ़ते आ रहे first year से biochemistry में. This inheritance, this enzyme deficiency. But if you have not seen a Fabry's patient, I have been lucky enough. I got to see a Fabry. It's a rare disease. Let me tell you. When I was doing medicine, I never saw this disease. When I'm doing nephrology, I did get to see a patient which was already diagnosed by CMC Vellore, and he had come to us just for a follow-up. So, yes, Fabry's ka presentation is usually in the second and third decade only. So 15 to 30 years is usually the age at which it presents. Is it clear? Good. Yes, 27. And I'm already seeing a few people have still spamming me. But yesterday I have taken a lesson. I have taken in the stride. I will not be catering to those who are spammers. I will be catering to 99% of those who are actually sending me love smileys, and I know who are actually enjoying studying medicine with me. Medicine is one subject that doesn't let you sleep. I used to go post my call duties like after 38 hours 38 hours of duties, and if I were to see an interesting patient, I would still go back and I would have the urge to go open the book and try to find out what is this. It rises the Sherlock Holmes in you. This is the beauty of medicine. Abdominal telangiectasia is angiokeratoma. Yes. Now, let's begin with acute kidney injury. New chapter, new page, new chapter, new page, and acute kidney injury. Let's start by defining. It is defined as abrupt decline in kidney function abrupt decline in kidney function, abrupt decline in kidney function leading to number one, accumulation of nitrogenous waste products, abrupt decline in kidney function leading to retention of accumulation of nitrogenous waste products. Arey, medicine is beautiful. Don't take me towards that conversation, otherwise I can go non-stop. I always feel medicine is a jungle ka raja. Medicine is the king of the stream that we are studying right now. Without medicine, I'm a hardcore lover of medicine, a disciple of medicine. That is why my Facebook page says love for medicine. Because though I am doing nephrology now, but there's nothing like medicine. So it leads to accumulation of nitrogenous waste products, and number two, dysregulation of fluid electrolyte acid base balance. So the definition of AKI, if you are asked in your prof exams, you will say, sir, acute kidney injury is abrupt decline in kidney function leading to accumulation of nitrogenous waste products and dysregulation of fluid electrolyte acid base balance. So you understood what is AKI? You understood everything? No, you understood nothing. Arey yaar, accumulation of nitrogenous waste products kitna? How much? Dysregulation how much? In what time? It's a non-specific definition. Absolutely bogus definition. No, not at all. Only you can just write it for a definition purpose. But what is AKI? AKI, you have to be very, very specific in medicine. You can't go beating around the bush. You have to say, sir, it is rise by itna in itna time. So basically, we have a body, international body in kidney, which is known as KDIGO. Kidney Disease Improving Global Outcome, not required the full form. KDIGO has defined the diagnostic criteria of AKI as, please write down with me, all of you, please write it down. Number one, increase in serum creatinine by more than equal to 0.3 mg per dl within 48 hours. So sir, the creatinine will rise by more than equal to 0.3 mg per dl within 48 hours. So sir, if today it was 1 and if tomorrow it becomes 1.5, so it has rose by 0.5, which is more than 0.3, so sir, it is AKI. Or sir, increase in serum creatinine more than equal to 50% from the baseline within 7 days. Sir, if the creatinine say we could not diagnose it within 48 hours. So sir, if the creatinine on day 1 was 1 and sir after day 6 it has become 1.6. Now the rise has been 0.6, and because 0.6 is more than 50% of 1, which is 0.5, so that is also known as AKI. Is it clear? Now it also has the importance. Man lo, please write it. Yes, please write down the diagnostic criteria. Now, very important. Say a patient had a baseline creatinine of 2. With a baseline creatinine of 2, he came to you on day 1 it was 2, on day 5 it became 3.2. So here what you have to think is that sir, within 7 days he has come to me with a rise of 1.2. And 1.2 is 50% of the baseline, that is 2, is 1. And 1.2 is definitely more than 1. So the rise in creatinine is more than 50% of the baseline creatinine, which could be higher from the normal also. So this also is AKI, and because it is on a background of high creatinine, we usually call it AKI on CKD. So it is background was something, uske upar there was an acute insult, and we said acute on chronic. Is it clear? Is it clear? Last but not the least, sir, I don't want to wait till 48 hours, till 7 days, sir. So then the injury will already be done. I want to nip it in the bud, sir. Alright, chalo, you do something. You measure the urinary output. So, sir, if the urinary output is less than 0.5 ml per kg per hour for more than 6 hours. So, say if a person of 60 kg has less than 30 ml per hour, that is in 6 hours, he has less than, in 6 hours, a 60 kg person in 6 hours has less than 180 ml of urine, that also is defined as AKI. And out of the 3, if any criteria is met, only one has to be met. Clear? Only one has to be met. That is AKI. So I am repeating, rise more than 0.3 mg per dl within 2 days or 48 hours, rise more than 50% within 7 days, or sir, more than less than 0.5 ml per kg per hour for more than 6 hours is also acute kidney injury. I hope I am absolutely clear. If any of the 3 are met, it is acute kidney injury. So now we have understood that what is acute kidney injury. Okay? Now let's get back to our traditional form of writing. Yes. So we have understood that this was the KDIGO diagnostic criteria. But sir, once it has been diagnosed, what if we have to classify that? For that, we follow the classification criteria. And that classification criteria is known by the acronym RIFLE. So, the classification criteria of AKI is known as RIFLE. The rifle with which you shoot. Yes, you are correct. So, that rifle, what is the full form of rifle? That rifle is known as risk injury. Please, it will require a lot of space. So please have adequate space both vertically and horizontally. If you want, you can write on a fresh page. Baad mein mat bolna, sir, I didn't give you enough. I didn't first warn you. Okay. So horizontally also it will require a lot of space. This entire table. Okay. Risk, injury, failure, loss, end stage. So the acronym is R for risk, I for injury, F for failure, L for loss, E for end stage. Okay. Okay. Now, how do you classify AKI that is basically on 2 parameters? One is serum creatinine, and one is urine output. First write down, then I will explain you everything. I will give you an example also. Don't worry, don't worry. Now serum creatinine here, it is not what we write. We don't write the base, we don't write the absolute value. We basically mean times the baseline. What do you mean by that, sir? I am clearing it. Don't worry at all. Don't worry at all. So when I say stage risk, so the serum creatinine is 1.5 to 1.9 times the baseline. In stage injury, it is 2 to 2.9 times the baseline. It is in risk in stage failure, it is 3 to 3.9 it is more than 3 times the baseline. In stage loss, it is RRT for more than 4 weeks, and in stage end stage, it is RRT for more than 3 months. Is it clear? Absolutely clear? No, Kiara Kapoor, it is not my last lecture. I am not going to leave you so early. I will be there with you for more couple of days. Okay? I want to, many students have given me a lot of requests that sir, ye bhi padha do, ye yahan pe chhut gaya hai, and all that. So I will try to cover them all. Okay? And I will teach lot many things which I have never ever taught till now. Never ever taught. Because don't get time also and all that, but some things are overlapping between neuro, endocrine, cardio, and usually neuro wala things endo will be teaching, endo things cardio wala will be teaching, but ultimately it is not taught, but they are asked in MCQs. So I will be teaching you those also. RRT means renal replacement therapy. Now coming to urine output. Urine output in risk, the urine output is less than 0.5 ml per kg per hour for more than 6 hours. In stage injury, it is less than 0.5 ml per kg per hour for more than equal to 12 hours. Okay? Yes. In stage failure, it will be number 1, less than 0.3 ml per kg per hour for more than equal to 24 hours. Number 2, it will be anuria for more than equal to 12 hours. Or number 3, it will be initiation of RRT. So this is how you classify AKI. This is the rifle staging. This is the rifle staging of AKI. I hope I am absolutely clear to all of you. RRT means renal replacement therapy. Now just have a look. Just see how to remember this. This is very, very easy. The creatinine value 1.5 to 1.9 times. So the baseline was 1 and it becomes 2.5. So how much is 2.5 times 1? It is 2.5 times. So it is injury. Now say if the baseline was 2 and now it has become 5. So how much times is 5 of 2? How much times? What do you multiply by into 2 that will become 5? That is 2.5 times. So if the creatinine is 5 does not mean it is more than 3, so it will be failure. No, because it is 2.5 times the baseline. You can write times the baseline in everything. Times the baseline. If you don't understand this. So if it is 2 say becoming 5, so it is becoming 2.5. It is becoming 2.5 times the baseline, and because it is become 2.5 times, it will still be risk injury. I hope I am absolutely clear to all of you. Okay? First one is more than 6 hours. Now this is very, very easy. Now come to urine output. See, in the stage risk, the urine output was less than 0.5 ml per kg per hour for more than equal to 6 hours. That was basically the diagnostic criteria. Now if the urine continues to be low for more than 12 hours, माने 6 से 12 घंटे हो गए, still it is not risen and it is less than 0.5 ml, now it is becoming stage injury. Now, 6 hours, 12 hours, 24 hours, 48 hours, 72 hours, 96 hours, 100 hours, 120 hours, 130 hours, 140 hours, 150 hours, 160 hours, 170 hours, 180 hours, 190 hours, 191 hours, 192 hours, 193 hours, 194 hours, 195 hours, 196 hours, 197 hours, 198 hours, 199 hours, 100 hours, 101 hours, 102 hours, 103 hours, 104 hours, 105 hours, 106 hours, 107 hours, 108 hours, 109 hours, 110 hours, 111 hours, 112 hours, 113 hours, 114 hours, 115 hours, 116 hours, 117 hours, 118 hours, 119 hours, 120 hours, 121 hours, 122 hours, 123 hours, 124 hours, 125 hours, 126 hours, 127 hours Now, the urine, as we go down, because we are entering into more severe form, see, the urine limit from 0.5 becomes 0.3 and the duration from 12 becomes 24. So now, if further the urine output drops to less than 0.3 for more than 24 hours, it becomes stage failure. Now what we did, we further decreased the urine output and we made it anuria, less than 100 ml per day. For more than 12 hours, so that is less than 100 ml for more than 12 hours, it is still stage failure. Or, sir, so much so that nothing, sir, we had to start renal replacement therapy. By that I mean dialysis. So then it is stage failure. And now, sir, if this stage failure continues for more than 1 month or 4 weeks, that is stage loss. If for more than 3 months, that is stage E or end stage. So we do not say stage 1, 2, 3, 4, 5. We say stage loss, stage risk, stage injury, stage failure, stage loss, stage E. Is it clear? No. Anyone can be same. Both do not have to be met. Either one. Is it clear? Either one can be met. And out of the 3 in failure also, anyone if met, I am happy. If anyone, or 1, 2 or 3, anyone. Clear? Now basically, I have seen very many patients of AKI, but I think the most wonderful example that I have seen in my practical life as a medicine postgraduate was a hematotoxic snake bite. Okay. So in my second year of residency, a hematotoxic snake bite came and the patient ultimately developed acute kidney injury. Okay. Say on 5th or 6th day, he absolutely landed up in acute kidney injury advanced, obviously started on the second day only. So what happened was, in the very first day, I saw that his urine output was declining. So I told to myself that yes, his urine output has not come for more than 6 hours, he is stage risk. And when it did not rise for more than 12 hours, I knew it was stage injury. Now the serum creatinine kept creeping up on the 3rd day and I knew he was not passing urine. So I knew he was developing acidosis. So I had to begin him on renal replacement therapy, that is dialysis. And if you ever begin a patient on dialysis, as a lay person, what will his attendant or family member ask me? His wife, the first question she asked me, sir, please tell me, sir, till when dialysis, sir? Sir, dialysis kab tak karoge? This is the question. And what did I answer? I said, I don't know. Because I actually don't know. So I did not have an answer. So I said this and she went away with a very, very angry and sad face. Now I was continuing with the dialysis and we were continuing to dialyze him thrice a week and continuing dialysis, continuing and ultimately 1 month passed. When 1 month passed, she again came back to me and I told to myself that Vivek, she has entered into stage loss. She came back to me, sir, please tell me, ab to bata do, till when will you dialyze my patient? And what did I answer? I said, I don't know. She said, sir, any chance of improving, sir? I said, ma'am, there were definitely chances, there are chances, but it should have started to improve by now. She again went till when? She again asked me, sir, when? Till when? I said, ma'am, you will not get a figure from my mouth because I will not commit which I actually don't know. So I said, ma'am, I do not know. Now, dialyze karte, we discharged him, but he was still coming on OPD basis getting dialysis. He got dialyzed and now 90 days had passed. And now again from a distance I saw in the corridor that woman came walking with me in slow motion. And now I was not hiding my face. In fact, I was not smiling in a bad sense, but I was a bit confident. And when she came to me and asked me, sir, Now please tell me, sir, please stop this, sir. And then I answered, ma'am, let me tell you, when your husband had come to me, he was a patient of acute kidney injury. And now, ma'am, because 3 months have passed, and ma'am, as I know, as I have told you before, that when a kidney injury persists for more than 3 months, it is known as chronic kidney disease. So ma'am, now your patient is no longer a patient of AKI. He has become a patient of CKD. And now probably, ma'am, your patient will never having stopped dialysis. He will never be able to stop dialysis. So better, ma'am, you plan for a renal transplant. So this is how the rifle staging helped me to understand the progression of AKI and how to prognosticate a patient. Is it clear to all of you? Is it clear to all of you? Good. Now, I hope you are absolutely clear. Now, so these were the rifle staging of AKI, and now let's begin the phases of AKI. Those were the stages of AKI. These are the phases of AKI. These are the phases of AKI, and these are totally the clinical phases. Because the rifle staging was somehow dependent on the lab reports also. But clinical phases are absolutely clinical more or less. How do you say what are the phases of AKI? The phases of AKI are defined as number 1, initiation phase. Number 2, oliguric phase, also known as maintenance phase. Number 3, diuretic phase. Number 4, recovery phase. Is it clear? Yes, the person can return from stage loss also, but from E of end stage, the person does not return usually. Okay? Actually, I'm very afraid of saying no or never in medicine. I can never say no or never. I am saying no or never because it has not been reported yet. Kal a case report is there and it is included in a textbook, so exceptions are also excluded. So never say never in medicine. Just say usually does not happen. This is a more humble way of doing it. So these are the phases of AKI. Okay, the initiation phase is in the first 2 days. Oliguric phase is 2 days to 2 weeks. Diuretic phase is 2nd week to 4 weeks, and recovery phase is after 4 weeks. Clear? The table is phases of AKI. Phases of AKI. A girl messaged me yesterday, sir, why do you only give tables, sir? Let me tell you, my dear students, all these are written in the form of text in all standard textbooks. Okay, so it really requires a lot of understanding and effort to convert text into a table, because a table is the easiest form to learn. Clear? No, both should not meet. Who's asking me for the 7th time? I am also answering both should not meet, only one should meet. Next. Now, talking about serum creatinine, what will be the serum creatinine? Urine output, and what will be any advice or treatment if there will be at all. Clear? Now see, in the initiation phase, what do you mean by the initiation phase? What do you mean by the initiation phase? Okay. Don't write treatment, write down clinical features and treatment, if any. So now in the initiation phase, what do you mean by initiation phase? Initiation phase means, sir, today injury has occurred to the kidney, any form of injury, say a snake bite has occurred or whatever. In the first 2 days, usually the serum creatinine is normal, the urine output is normal, there is no clinical feature, and no treatment is required. In the oliguric phase, as the name implies, there is oliguria, so urine output decreases, the serum creatinine increases, and obviously the patient usually has symptoms of fluid overload. And what will you treat? You will say, please restrict water. Please sir, restrict water, don't consume extra water. Clear? Next, in the diuretic phase, and the name implies, now the person has started to improve, his urine output will increase, his serum creatinine will start decreasing, and now because he's having a diuresis, he will now be in a dehydrated state. And now the treatment will be liberal water intake. Last but not the least, sir, now after 4 weeks, creatinine normalize, urine output normalize, everything normalize. So basically this is how an AKI progresses in phases, where in the initiation phase, just injury has occurred, so there can be no symptoms, urine output normal, creatinine normal, clinical features nothing. So the doctor is very happy, the patient is super happy. Both are unaware. Next is the oliguric phase. Sir, now the thing has started to begin, and now the creatinine has risen, urine output has come down, and basically because urine is not being passed, so there is urine is being retained in the body, so the patient will have fluid overload. Or आप patient को बोलोगे, sir, please consume less of water, or sir, your JVP will start to dance, your chest will have a lot of crepitations, or sir, आपके slippers will become tight because you can have pedal edema. So there will be fluid overload. Is it clear? In diuretic phase, as the name says, sir, now the patient has started to improve, and usually the urine output will be more. And when the urine output will be more, the creatinine will start to decrease. And sir, now it may so happen, if you don't keep up in the adequate intake state, the patient may have a volume depleted state. And last but not the least, sir, recovery phase where everything becomes hunky-dory and everything normalizes. Now this is the ideal phase of an AKI, but let me tell you, as all of you are not ideal students, I am not an ideal teacher, so every AKI does not follow this path. Is it clear to all of you? So these phases of AKI, whenever a standard is formulated in a house, it is always formulated keeping whom in mind? The naughtiest child or the most ideal child? The ideal child. Similarly, the prototype of AKI is acute tubular necrosis, and these phases have been made keeping in mind ATN. Is it clear to all of you? Keeping ATN in mind, these phases have been kept, but just remember, all of them will not follow the same phase. Is it clear? Absolutely clear? Good. So we have completed the clinical staging, the rifle staging and the clinical phases of AKI. Now let us start by classifying AKI, and AKI is classified into pre-renal, intrinsic renal and post-renal. So very simple, whenever I see this, I am reminded of the classification of jaundice and portal hypertension. We classify jaundice into pre-hepatic, hepatic, post-hepatic. Causes of portal hypertension into pre-hepatic, hepatic, post-hepatic, pre-sinusoidal, sinusoidal, post-sinusoidal. Yes or no? Give me a cheer. Yes, I know that. This is the way. So similarly, we classify AKI into pre-renal, intrinsic renal and post-renal. In pre-renal AKI, there is no structural defect. So there is no structural defect of anything here. Kidney is just bearing the brunt. In intrinsic renal, there is a structural defect in the kidney. And in post-renal defect, sir, as the name says, post-renal, it means beyond renal, the structural defect is beyond kidneys. Clear? Now, let me tell you, this domain is not my domain. This is the domain of your urology teacher, because usually all of these are surgical entities and require surgical intervention. So I will not be dealing with all of them. Now if I have to give you an example of each, a pre-renal can be due to dehydration. Intrinsic renal can be due to GN or ATN, and a post-renal can be due to stone. Benign prostate hyperplasia. Is it clear? Absolutely clear? Very good. So this will be taught to you in your urology class. Now let me ask you some most commons. Most common cause of AKI. Most common cause of pre-renal AKI and most common cause of intrinsic AKI. Let me see who is the champion who can answer all the three questions for me. The most common cause of pre-renal AKI, is pre-renal. So I gave the answer in the question only. Very similar to, the famous dialogue from the movie Sholay, that तुम्हारा नाम क्या है बसंती? Khair, I know all of you are Caesar students, you don't watch movies. Most common cause of pre-renal AKI is hypovolemia. And most common cause of intrinsic AKI is acute tubular necrosis. And let me tell you, these two questions, so simple but have been asked in the last 2 years All India postgraduate examination. Is it clear? So these are the very important MCQs. Now I hope all of you remember the physiology part which I taught you the very first day about the afferent arteriole. Afferent arteriole was the entry gate of my class, and that was dilated by the prostaglandin. Efferent arteriole was the exit gate of the class, and the Darwan who was sitting at the exit gate not allowing anyone to go out was angiotensin 2. Very good, absolutely correct. Now let's start with pre-renal AKI. Post-renal will be stone or benign prostate hyperplasia. Post-renal stone BPH. Clear? Now, pre-renal AKI. So now the causes of pre-renal AKI can be, sir, number 1, hypovolemic shock. So the causes will be, sir, there is less of water in my body. Sir, मेरे body में पानी बहुत ही कम है. Sir, it is hypovolemic shock. And the causes can be, sir, I am losing water from my body. I am losing volume from my body. So, sir, if I lose volume from my mouth, that is known as vomiting. If I lose volume from my anus, that is known as diarrhea. If I lose volume from everywhere, a cause can be pancreatitis. Or if I lose excess of blood, that could be road traffic accident. So if you lose volume from any, definitely it will be clear. मजा आता है, कंपेयर करके पढ़ाओ सर, मजा आता है बेटा. डोंट टेक टू मच ऑफ मजा. Okay, I'm just kidding. Take it. So basically, how do you treat each of them? What is the treatment of the fluid of choice in each? So, just asking you for general common sense. If it is vomiting, what is the fluid of choice in vomiting? It is normal saline. In diarrhea, the fluid of choice is, if the patient can take orally, it is ORS. If the patient can't take, it is Ringer's lactate. In pancreatitis, the fluid of choice is normal saline, which is absolutely the wrong answer. Answer is Ringer's lactate. And in road traffic accident, खून के बदले खून. Burns also will be Ringer's lactate. Yes, correct. लिख दो. So, this is the fluid of choice. Now, sir, I have a lot of pani in my body, sir. I have a lot of water, sir. But sir, my pumping machine is out of order. Sir, my pumping machine is out of order, sir. Because my pumping machine is out of order, I am not being able to pump enough fluid or blood into my kidneys and they are bearing the brunt, sir. So they are cardiogenic shock. Sir, that could be due to acute myocardial infarction or due to left ventricular failure, acute LVF, due to whatever reason. Is it clear? And please tell me one more thing. If heart failure causes kidney failure, if heart failure causes kidney failure, what is that known as? So if heart failure causes renal failure, that is known as cardiorenal syndrome. So what is cardiorenal syndrome? If cardiac failure or heart failure causes renal failure, that is known as cardiorenal syndrome. Is it clear? Very good. So this is cardiogenic shock. Next, sir, I have a lot of water in my body. My pumping machine is also okay. But sir, the problem is there is a lot of traffic in my blood, sir. There is a lot of traffic in my blood. And you know what do I mean by traffic? I mean hyper viscosity syndrome. So basically, there is a lot, my blood has become very thick, very viscous. Sir, why, sir? You know, hyperviscosity syndrome was my short note in my final year MBBS medicine paper. And I did not know much about it, but I wrote it quite decently. Why? Because I knew for blood to become thick, the cellular components have to increase. So if RBC increases, that is known as polycythemia vera. If WBC increases, that is known as leukemia. If platelets increases, that is known as essential thrombocytosis. If plasma cell increases, that is known as multiple myeloma. Is it clear? Is it clear? So sir, all these are hyperviscosity syndromes. So they will also obstruct the flow of the blood to my kidneys. And you remember kidneys receive 20 to 25% of the cardiac output. I told you the master diagram yesterday on the very first day. Very good. Very good. Clear? Next, sir, I have pani in my body. My pumping machine is also okay. There is no traffic also. But sir, my kidney is giving me problems because there is altered diameter of afferent arteriole is to efferent arteriole. Sir, what do you mean by that, sir? MM means multiple myeloma. Multiple myeloma. Sir, in normal circumstances, I want my afferent to be dilated, my efferent to be constricted, so that blood does not go out, my intraglomerular pressure rises, GFR increases. This is my normal. But sir, if my afferent becomes constricted, and this is leave it, or sir, my efferent becomes dilated, what will happen, sir? Sir, मुझे तो आपकी स्टोरी याद आ गई. I am reminded of the story you told me, and I know my afferent is dilated by prostaglandin, my efferent is constricted by angiotensin 2. So sir, if at all my afferent gets constricted, that has to be a prostaglandin depleter. So the answer to that is the prostaglandin depleter is also known as NSAIDs. And sir, if my efferent has to be dilated, it is definitely my ACE inhibitor or ARB. ET means essential thrombocytosis. You must be knowing hematology much better than me. You are studying from Dr. Sanjeev sir, Dr. Ranjit sir and all such great teachers. Okay. And I had studied last I don't know when. Okay. So, NSAIDs and ACE inhibitor ARB, I told you that story, nagging neighbor auntie, which, blood pressure, telmisartan, 40 mg, creatinine rise, Dr. Google, washroom. Yaad aaya? If you can remember, just give me a love wala smiley. Give me a love wala smiley. Okay, and the rich people told her, go and get a transplant done. Please don't tell her. Okay. Alright. Now, next. Last but not the least. Sir, मेरे बॉडी में पानी भी ठीक है, मेरी पंपिंग मशीन इज ऑल्सो ओके, देयर इज नो ट्रैफिक इन माई ब्लड ऑल्सो सर, एंड सर द किडनीज माइक्रो सर्कुलेशन इज ऑल्सो गुड, बट सर देयर इज altered resistance in systemic vasculature versus renal vessels. Thank you. So if there is altered resistance, the systemic vessel and the renal vessels, they have to maintain a homeostasis so that adequate blood flows from the systemic blood vessel to the renal vessel. Is it clear? So now, if there is an altered resistance, sir, what do I mean by that? So if the systemic vessels develop severe vasodilation, and the renal vessels are same, or sir, if the renal vessels develop severe vasoconstriction, and the systemic is same, or sir, the most grave thing, sir, if the systemic vessel develop vasodilation and the renal vessel develop vasoconstriction together, Is it clear? So just see. So if there is tell me a condition where there is profound systemic vasodilation. Profound systemic vasodilation, yes, you are correct. It is septic or anaphylactic shock. Septic or anaphylactic shock. Tell me a drug that does profound renal vasoconstriction. It's an antifungal drug. You are correct. It is amphotericin B. Amphotericin B. And last but not the least, sir, happening both together, sir. Meaning, sir, there is vasodilation in the systemic vessels also, and there is vasoconstriction in the renal artery also. What type of a condition is this? What condition is this, sir? What condition could it be this, sir? You can't recall right now, but I'm pretty sure most of you have already heard this terminology, because most of you have entered medicine wards and you must have seen some patients known as cirrhosis of liver or CLD, and that cirrhosis of liver patients, and if you're most of you in your final MBBS practical exams, medicine exams, you will be getting a case of what? CLD, chronic liver disease. And when your teacher will ask you, tell me complications of chronic liver disease, so there are some over smart studious fellows, सबके क्लास में होते हैं, who try to mug everything up from before and they try to act over smart. There were a few chaps in my class also, and such a student in the Viva exam, he said, sir, there are many complications, sir. The complications are hepatopulmonary syndrome, sir, hepatorenal syndrome, sir, I know what will be the next question. Beta, tell me, what is the diagnostic criteria of hepatorenal syndrome? What is the diagnostic criteria of hepatopulmonary syndrome? Which of course you will not know and you will get stuck. And a less learned, humble and a less knowledgeable person like me will go very, very slowly, step by step. I will say, sir, the complications of chronic liver disease are, sir, jaundice, sir, ascites, sir, upper GI bleed, sir, esophageal varices, sir, hepatic encephalopathy, coagulopathy. So I will be like this, going very, very slow. And when the teacher will ask me, tell me some more, good Vivek, tell me some more, then I will in a very slow voice utter, sir, hepatorenal syndrome, sir, hepatopulmonary syndrome. Because it is an art. In a Viva exam, you can lead the examiner where you want to. So if you are over smart and you want to answer extra, you will be doomed. Is it clear? So you are correct. This condition is known as hepatorenal syndrome, which you will be taught in details in your GIT class. So wait for GIT class. Is it clear? Absolutely clear. Now quickly tell me, how do you treat hepatorenal syndrome? You will do kidney transplant or liver transplant? Sir, hepatorenal syndrome mein, what will you do, sir? You will do kidney transplant or you will do liver transplant? Sir, obviously kidney transplant, sir, because we are studying acute kidney injury, sir, because the kidney has failed, sir. Hai na? We will do kidney transplant? Absolutely wrong. Sir, kidney transplant we will not do, because it is not the fault of the kidney at all. It is a liver who has failed and it is a kidney who is just bearing the brunt of the liver failure. So the treatment of choice of hepatorenal syndrome is liver transplant and not kidney transplant. Is it clear? Absolutely clear? Very good. So with this we complete the causes of pre-renal AKI. Okay? Good. Now come to intrinsic renal AKI. Come to intrinsic renal AKI. Now intrinsic renal AKI के causes are again very easy. Just you need to know the parts of the nephron. The parts are glomerulus, the glomerular, tubular, interstitium and vessels. Kidney is basically made up of these four things. Yes or no? Basically, the entire organ is these four things. Clear? Shiksha yes Upadhyay. If anything has a side effect, if will not be prescribed, then practically the entire allopathy will have to be stopped. Because practically everything has side effect. Clear? So, if the cause is glomerular, it is basically glomerulonephritis, which I have already taught you in details. I have taught you already in details. If the cause is tubular, it is basically acute tubular necrosis. If the cause is interstitial, it is known as acute interstitial nephritis. Acute interstitial nephritis. Coming to vascular, sir, vessels can be, the vessels involved can be small vessels or they can be large vessels. Sir, if it is a large vessel, obviously there are two large vessels. It could be renal artery embolism or renal vein thrombosis. If it's a small vessel, it is obviously vasculitis. There could be thrombotic microangiopathy. Thrombotic microangiopathy. So these are the causes of intrinsic AKI, and I have already taught you glomerular. The rest I am set to teach you, and I will not write the full forms anymore. I will only write ATN and AIN. I hope I am absolutely clear to all of you. Clear? Absolutely clear? Very good. Very good. Now, so you have come across two very similar sounding terms today. You have come across two very similar sounding terms today, and the terms are ATN and AIN. Let us see how do they differ, or they differ at all. Yes sir, they differ at all. They definitely differ. And let us see how do they differ. Let us see what are the causes of each. Okay? The causes of each are, come to acute tubular necrosis. The causes of acute tubular necrosis are, number one. Now see, why are you all here? You are all here because you are not here. You are all here because you are not here. And why are you not here? I would like to believe because आपने किसी को IIT दिया. You know, at least I would believe, not because you are here because you could not crack it, but because you gave it to someone else. Yes or no? And trust me, you are at a very happy place. If you have not realized till now, let me tell you, you are a very lucky person and you are very at a happy place. So what are the causes of ATN? The causes are ischemia, infection, and toxins. Sir, what do you mean by ischemia? By ischemia I mean, and the causes of AIN are drugs, which are the most common, infection, and autoimmune cause. Is it clear? Now, basically by ischemia I mean hypovolemic or cardiogenic shock. Hypovolemic or cardiogenic shock. Coming to infection, I basically mean sepsis. Any sepsis can cause ATN. And last but not the least, toxins. The toxins can be endogenous or they can be exogenous. Is it clear? The endogenous means you have not consumed that from outside. आपने बाहर से सेवन नहीं किया है. They are created inside your body. So the exogenous toxins that you have taken from outside, number one are, what are the toxins? They could be snake venom. Number two, drugs like amphotericin B. Number 3, aminoglycoside. Number 4, calcineurin inhibitor like cyclosporin, tacrolimus. And last but not the least, what are the exogenous toxins else that you can consume? That is contrast. You take any contrast for, you take contrast for a imaging. It could be a contrast for an angiography. It could be a alienated contrast for a CT scan. All that can cause, that's basically a radio contrast, can cause acute kidney injury. Is it clear? Absolutely clear? Very good. So these are the exogenous toxins, and if I have to mean endogenous toxins, I will discuss that later. Please write down 2 star marks and I will discuss that later. Is it clear? Now come to acute interstitial nephritis. The causes of acute interstitial nephritis are drugs, infection, autoimmune, and the drugs that cause AIN are antibiotics, diuretics, analgesics, anticonvulsants, and miscellaneous. So the drugs that cause AIN are antibiotics, diuretics, analgesics, and miscellaneous. Now antibiotics consuming AIN is a chapter in itself. There are so many antibiotics that cause AIN or acute interstitial nephritis. So I will not tell you the names of the antibiotics that cause AIN. Instead, I will tell you which don't cause AIN, which are very important for MCQ. So basically, I am telling you which don't cause AIN, and the antibiotics are number 1, aminoglycoside, amphotericin B, or isoniazid. The antibiotics that do not cause AIN are aminoglycoside, amphotericin B, and isoniazid. Very, very important. Diuretics can cause, analgesics can cause, anticonvulsants. Miscellaneous में practically every drug can cause. So miscellaneous as a drug which I even consumed the day before, which is proton pump inhibitor. And trust me, I have seen a patient of PPI induced AIN. I have seen one patient, because that patient actually had a presentation similar to AIN. I will tell you what did he present with, and we could not find any infection or toxin or offending drug that he had consumed. So actually he had consumed proton pump inhibitor. Clear? Absolutely clear? Next. Clear? Now there are many infections that can cause AIN. Can be Legionella, staph, strepto, etc. And the autoimmune disease, which is the MCQ point, which causes AIN, and I think you already know that. You already know that by your rheumatology class, and that autoimmune disease is Sjogren syndrome. I taught you yesterday, I taught you how I saw a patient very recently, and I'm writing a case report also, probably I write it tonight. I saw Sjogren syndrome. So if I ask you, what are the renal complications of Sjogren syndrome? You will tell me, sir, it is salsa ka S, it is type 1 renal tubular acidosis, and number 2, it will be acute interstitial nephritis, and both of them are MCQ points. Both of them are MCQ points. Is it clear? Absolutely clear? Very good. Very good. Sjogren or Sitka syndrome. So, if I ask you, these are the causes in a nutshell of ATN and AIN. ATN has IIT and AIN has DIA. DIA for drugs, infection, autoimmune, and of course the 3 antibiotics that do not cause are this, and this is this. Now suddenly, let me highlight you that I have written 2 names here, and I have written 2 names here, and I have written 2 names here. So let me strike your hippocampus once more, and let me revise it once again for you. The take home message is amphotericin B and aminoglycoside both cause ATN, and that both do not cause AIN. This is the take home message which you will remember for MCQ purpose. They both cause ATN, but they both do not cause AIN. So you have understood the causes of ATN and AIN. I hope I am absolutely clear to all of you. I hope I am absolutely clear to all of you. Clear? Now, next, clinical presentation. Clinical presentation is of ATN will depend on the cause. Depends on cause. If the snake bite will cause ATN, obviously it will be snake bite induced. Snake features of that. So that will be just, and the specific features will be nothing but depending on the cause and degree of uremia. I mean, how much the serum creatinine and urea have risen in the blood depends on that. The features of AIN are, number 1, fever, rash, eosinophilia. Fever, rash, eosinophilia. Endogenous toxin I will discuss later. Fever, rash, eosinophilia, and this is the famous triad of acute interstitial nephritis. Though it is not present in 100% patients, in a few patients only, but it is a classical symptomatology of AIN. Now, if you investigate this patient in the urine, if you please can recall, acute tubular necrosis means death, death means sloughing, sloughing means gandagi, dirty, dirty means which caste? You will get granular or muddy brown caste. Very good. And here you will get the classically, as it is the allergy of the kidney, you will get eosinophil caste, and you can also get WBC caste. You can also get WBC caste. Clear? I hope I'm absolutely clear to all of you. Am I clear? Very good. Very good. Now, next. Next is the treatment. Uremia means rise of bun and creatinine. The symptoms due to rise of bun and creatinine in the blood. The symptoms due to rise of creatinine and urea in the blood. The treatment. What is the treatment of ATN? The treatment is nothing but supportive. Treatment is nothing but supportive. You just have to treat the cause. You have to just treat the cause, and whatever the symptoms are, if the symptoms are fluid overload, give diuretics. If the fever, give paracetamol. The treatment of AIN is, the AIN, the main thing is drugs. So please stop the drug. And of any allergy, if any allergy, the ultimate treatment is what? Ultimate treatment is steroids. Ultimate treatment is steroid, obviously. And last but not the least, last point is very, very important, because you must know how much is the recovery. How much time will it take to recover? Because only then will you be able to prognosticate the attendant. So you must know the natural history of every disease. If you do not know, आप उसके घर वाले को क्या बताओगे? What will you tell to the attendants? So ATN, how will ATN and AIN recover? ATN takes more than 4 weeks to recover. Acha, which do you think is a more serious and more graver disease between the two? ATN or AIN? Sir, in AIN there is only allergy, sir, and ATN there is necrosis, sir. Necrosis means death, sir. So obviously ATN is more serious. So ATN will take more than 4 weeks to recover, and this will usually take 1 to 2 weeks to recover. I hope I am absolutely clear to all of you. So after the causes, I said this, and I think the table is already by-hearted by you. You know the causes of ATN are IIT. Here you have DIA. Here most important is this, drugs. Sjogren syndrome, I told you what? Cast is, granular cast, eosinophil cast. Start the drug, steroid, and more than 4 weeks, 1 to 2 weeks. So already you have by-hearted with me ATN and AIN. Very good. And the take-home message, aminoglycoside, notorious to cause ATN, but they do not cause AIN. Absolutely clear to all of you? Absolutely clear to all of you? Very good. Very good. And in this topic, I told you that I have discussed everything, but not the endogenous causes of ATN yet. I have not discussed endogenous causes of ATN yet, and so let me discuss the endogenous causes in my style. And because I know you people are really good at correlating clinical scenarios, so let me discuss some patients of mine. Do you want to listen to some patients of mine having ATN? Give me a thumbs up. Give me a thumbs up if you want to. If you want to, please give me. Or should I just make you write in one sentence everything? If you want clinical scenarios, give me thumbs up. So basically, I am discussing the exogenous toxins. Which I marked with 2 asterisks. Good, very good. So the exogenous toxins of ATN. What are the exogenous toxins? Sorry, endogenous. I'm so sorry, endogenous. जिसका सेवन आपने बाहर से नहीं किया है, जो आपने अंदर से ही खाए हैं, अंदर से ही प्रोड्यूस किए हैं. What can that be? Sir, very simple, sir. Sir, very simple, sir. Let me give you first example. Actually, this was a patient which I saw in my 3rd year of medicine residency. He was an 11-year-old male patient of acute lymphoblastic leukemia, and chemotherapy was given to him. Chemotherapy was given to him, and you won't imagine, the moment I started the chemotherapy, after 3 days, the patient developed AKI, and that is why I was called upon. And because I was called upon, so what I saw was the patient had, when I saw the reports, I saw the patient had hyperkalemia, hyperphosphatemia, hypocalcemia, and hyperuricemia. These were the investigations of the patient. These were the investigations of the patient. So can you tell me, can you help me diagnose this condition? Yes, some of you have already said, sir, after chemotherapy to a patient of cancer, if the patient develops hyperkalemia, hyperphosphatemia, hypocalcemia and hyperuricemia, and obviously his urine had xanthine crystals, so there was xanthinuria, there were uric acid crystals in the urine. Of course, you know uric acid crystals are what shaped? Diamond shaped, because uric acid crystals are painful in the gouty joint and they are needle shaped. And the diagnosis was tumor lysis syndrome. Tumor lysis syndrome. And tumor lysis syndrome, how do you treat tumor lysis syndrome? You give the patient forced alkaline diuresis plus RAS buricase. And my pharmacology champions already know what a RAS buricase is. It is basically a recombinant uric acid oxidase which converts uric acid to allantoin. And allantoin is a water soluble product which is excreted through the urine from the kidneys. So basically, why did I teach you this in AKI? Tumor lysis syndrome is not my topic. I taught you because here the toxin. What was the toxin? It was uric acid. And of course, you did not consume uric acid from outside. It was produced from inside. So it is an endogenous toxin. Very good. The next clinical scenario. The next clinical scenario is again a very, very interesting scenario. A very, very interesting scenario. I was sitting in my internship in the casualty and a road traffic accident patient. I don't mean renal tubular acidosis. I mean an accident patient. Yes, you have to write. If you don't want to write, that's not my choice, but you should write, obviously. Why should you not? Why should you not? Next is, what am I writing for? What am I writing for? Clear. So, talking about road traffic accident. Now, I was sitting in a casualty and a road traffic accident patient came to me and he landed up in AKI. And when he landed up in AKI, thankfully, when a surgery resident, after having excluded the bladder injury by ultrasound and stuff like that, when he catheterized the patient, and the patient had red urine. And if you remember, there were very few limited causes of red urine. So immediately something came to my mind, and when I got the test done, I saw the patient had hyperkalemia, hyperphosphatemia, hypocalcemia, and the patient had red urine with a road traffic accident in the background. And I came to know that understood what is it. So to diagnose the patient, I got this test and the CPK was 70,000. And you are correct. The diagnosis was rhabdomyolysis. This was the condition. And of course, why am I teaching rhabdomyolysis in AKI? Because the toxin here was myoglobin. The toxin was myoglobin. So myoglobin is here the toxin. Why am I teaching you this here? It is the toxin myoglobin. And how do you treat this patient? You treat this patient through forced alkaline diuresis. So it is the myoglobin that goes and clogs inside the tubules and causes necrosis of the tubular epithelium, causing ATN, which is an endogenous toxin. Now, next one. Very, very interesting. Might be a bit difficult for some. Let me see who answers this. I will be really very happy. A 40-year-old female, she told me, she came to us, she got admitted, and she said, sir, I am having severe right upper quadrant pain in my abdomen, and sir, she had jaundice. she had jaundice. When I took detailed history from the patient, the past history included that she had developed DVT in right lower limb 3 years back. So this patient she came to us, female, right upper quadrant pain and jaundice. She developed DVT in the right lower limb in the past history, and when I took more history from the patient, she said, "Sir, when I got up in the morning, my first pee in the morning was red. The clue lied in the morning and the first urine. Immediately there was a bell ringing in my ears, but still I thought, let me investigate. When I got a CBC done, I saw hemoglobin was 7.6, total leukocyte count was 3900, and the platelet was 95,000. So basically, she had a pancytopenia. So I got a pancytopenia on the background of this one, and ultimately I understood pancytopenia. And when I got the bone marrow done, it was a cellular bone marrow. And ultimately, when I saw a pancytopenia with thrombotic manifestations, I understood what is this, and I got a urine for HB done, and a urine HB was positive. So the patient was having hemoglobinuria, which had caused the red colored urine. Red colored urine was caused by hemoglobinuria, and when I checked CD55 mutation, that was positive. And you are absolutely correct. The diagnosis was paroxysmal nocturnal hemoglobinuria, and the treatment of PNH is of course eculizumab. I have seen 4 patients of eculizumab in my life till now, and they were all very, very interesting. And some of you might be thinking, sir, why did you tell us right upper quadrant pain and jaundice? What is this? Anybody can tell me why did I say right upper quadrant joint pain and jaundice? What is this presentation? You must, when you read PNH, you will understand that the most common presentation of PNH is thrombosis. So this is basically Budd-Chiari syndrome. So my patient had presented with thrombus in the hepatic vein. So my patient had Budd-Chiari syndrome and history of DVT, so thrombosis with pancytopenia, with hemoglobinuria, with CD55 positivity, and I got eculizumab and I got PNH, but I could not treat with eculizumab because the treatment cost of eculizumab is only 18 to 20 lakhs, which my patient could not afford. Clear? Last but not the least, last clinical scenario which I see almost very, very regularly in the nephrology practice. I saw a 70-year-old Dadaji. He presented to me with low back pain. I said, so what, Dadaji? There can be so many causes of low back pain, 1,000 causes. What is so special? He said, beta, the pain is so severe, I cannot sleep at night. And when I heard, you were asking me what is a toxin here. The toxin is hemoglobin. The toxin here is hemoglobin because it has caused intravascular hemolysis and it has caused hemoglobinuria. Low back pain, nocturnal pain. I was thinking, acha, so what? As soon as he said nocturnal pain, I immediately rose my eyebrows, understood not a mechanical low back pain, something very, very dangerous. I said, what more, Dadaji? He said, beta, I have been having recurrent lower respiratory tract infections. Recurrent infections. I wrote, okay. As soon as he said recurrent infections plus low back pain, my eyebrows were lit and I was thinking what to do. I thought in the meanwhile, let me get a complete blood count done, and I got the hemoglobin was 7.2 the ESR was 136. So I got severe anemia with a very high staggering ESR. And you know, in India, if you get a very high ESR, the first thing that comes to your mind is, of course, TB, without doubt. Because I told you, whenever I teach India, so I thought of TB, but his thing was not matching with TB because he was not having a low grade fever and stuff like that. Okay, but still I had that in mind. I got the X-ray did not have anything significant. So then I got a renal function test done, and when I saw calcium, the corrected calcium was 11.5 milligrams per DL, and I saw, when I got an LFT done, I saw albumin was 2.7 and globulin was 4.9. So basically I had the scenario of low back pain, recurrent infections, high ESR, hypercalcemia, hyperglobulinemia, and I understood what was this disease. Immediately I ordered for a serum protein electrophoresis and a urine examination. Serum protein electrophoresis obviously had your favorite, my favorite, an M-band, and urine had, of course, you know, BJP. I am an apolitical person. I mean Benz-Jones protein. And of course, the diagnosis was confirmed. I did a bone marrow also, and the bone marrow had 16% plasma cells. And you know, to diagnose how much plasma cell do you require? To diagnose myeloma, how much plasma cells do you require? That's the homework. Go and find it out. And I will ask in the thread. I want all of you to answer. That. Very good. And of course, I knew the diagnosis by now. The diagnosis was multiple myeloma, and the treatment is chemotherapy or bone marrow transplant. Okay? So with this, I understood. And please tell me, why am I teaching you multiple myeloma and acute kidney injury? Why? Am I so enthusiastic? No, I am not. Why? What is the toxin here? The toxin is free light chains. Okay? So here the light chains, but somebody is asking me, sir, why was I having infections, sir? Why was I having so much of infections? Though my globulin is so high, beta, you are having infections because though you are having a hyperglobulinemia, but they are all functionally bad. They are not functionally capable enough. So there is no hyperglobulinemia, but there is functional hypogammaglobulinemia, and you have the less functional antibodies, and so you have recurrent infections. I hope I am absolutely clear to all of you. So I taught you 4 endogenous toxins. I taught you hemoglobin, myoglobin, light chains, and I taught you uric acid, which I could have written in 4 letters, but I spent 20 minutes only to make you understand how patients will come to you as a clinician and how you have to diagnose them, how you have to treat them. Only then will my purpose be solved. Otherwise, I am a failure, which I think I don't want to be. I hope I'm absolutely clear to all of you. Very good. Rhabdomyolysis का ट्रीटमेंट है forced alkaline diuresis. Clear? Okay. MM means multiple myeloma. Last but not the least, how will you investigate AKI? How will you investigate AKI? To investigate AKI, you will first do an ultrasound, and by doing an ultrasound, you will exclude obstruction. Because if there is an obstruction, it's an obstructive uropathy, then I will not come into the picture and I will refer him to a urologist. मजा आ गया. I am super happy if you got मजा आ गया. If you said that. Okay. Okay. Very good. So chemotherapy, beta, please don't ask me. I don't, though I know it, but please don't ask me to tell you the chemotherapy and treatment of multiple myeloma also. Okay, please. Just one MCQ I can tell you. You now use proteasome inhibitors like bortezomib and carfilzomib. That's an MCQ, and that is a drug I am currently using to treat multiple myeloma also. Okay. In fact, today only I prescribed carfilzomib to a patient. Okay. Of course, with the consent and the help of a hematologist. Now, investigation of AKI. So after excluding obstruction, okay, after excluding obstruction, when you have excluding, so let's start investigation of an AKI. And your AKI basically you have excluded post-renal AKI. So now let's study pre-renal and intrinsic renal AKI. Pre-renal and intrinsic renal. Now let us take the example, one example of each. Let us take one example of each. Pre-renal example is cause would be hypovolemia, and intrinsic renal would be acute tubular necrosis or glomerulonephritis. So keeping this in mind, let's begin with it. Now if I ask you the pathophysiology, of pre-renal is because the kidney is not receiving adequate amount of blood. Or the person is dehydrated due to, let's keep hypovolemia as an example. So the patient has decreased effective intravascular volume, so this will lead to activation of RAS, and when RAS will be activated, you will want increased sodium and water reabsorption. So your kidneys and your tubules will be hungry for water and sodium. Jahan water sodium dikha, they will reabsorb it, and with sodium and water reabsorption, they will also reabsorb urate. I mean urea, sorry. So urea also will be reabsorbed along with sodium and water. Coming to acute tubular necrosis. Here your tubules are absolutely hampered, so there is decreased concentrating ability. And you will lose increased urinary sodium loss. Decrease reabsorptive. So basically, because your tubules are damaged, so you will not be able to reabsorb sodium, yes or no? You will not be able to reabsorb sodium. If you will not reabsorb sodium, you will have increased urinary loss. And yahan pe, this is the pathophysiology. Very good. If now you have understood this, now my task becomes very easy. So let's start with 1 by creatinine ratio. And let us discuss a few ratios. One is 1 by creatinine, one is urinary sodium, one is FeNA, and one is urinary creatinine by serum creatinine. Let us discuss 4 ratios here. Don't worry, I will explain it to you very simply. I told you in the very first class only. I told you in the second class, while I was discussing investigation of renal diseases, I told you that 1 by creatinine ratio in pre-renal AKI is more than 20 it is less than 20. Why is it more than 20? Because in pre-renal AKI, I told you in the pathophysiology, there is more urea reabsorption along with sodium and water. Because there is more urea reabsorption, the urea rises. And where is the urea? Urea is a numerator. And sir, if the numerator rises, the ratio will rise. Very good. Sir, very simple. In the pre-renal AKI, there will be more sodium reabsorption. So your urine will contain less sodium. And here, you are losing more sodium. Here, you are losing more sodium. So you will lose more sodium. Because you cannot reabsorb. Fena is basically, I will tell you separately what is Fena. Fena is fractional excretion of sodium. It is not a detergent. Fena is not a detergent. Fena is again a measure of reabsorption of sodium. So, I mean urinary sodium. So it is less than 1% in pre-renal, more than 2% in renal. I mean intrinsic renal. Is it clear? Now, look here. Please look here. Look here very carefully. I told you which is a more serious form of kidney injury. Of course, intrinsic renal. There is a structural defect here. So here the creatinine will rise more because the creatinine excretion will be hampered more because that's a more severe injury. So if the serum creatinine rises more there, so basically the denominator will be more where? In intrinsic renal failure. So if the denominator is more, the ratio will be small or less? Small or more? It will be less. It will be less. So here the denominator is less than 20. The numerator here is more than 40. Is it clear? Absolutely clear. Okay. And please do not try to overcomplicate it. Don't go into excess depth and molecular chemistry of everything. Just what I am saying, understand that. That is enough for you. There are plenty of things for you to learn. Okay. So I made you understand these two things. And of course, write down Fena is an MCQ, which has been asked many number of times. Now, let me give you a ratio of ratios. Let me give you a ratio of ratios. It is renal failure index. Renal failure index is nothing but, if this is point number 1, this is 2, this is 3, this is 4, and this is 5. So renal failure index is point number 3 by point number 4. Sorry, point number 2 by point number 4. What do you mean by that? You mean urinary sodium divided by urinary creatinine by serum creatinine. So it's basically a ratio of ratios. I will tell you what Fena is. I'm telling you again, urine creatinine by serum creatinine. Because serum creatinine rises more in which type of disease? This. Because serum creatinine increases more in intrinsic AKI. Because it's a more severe form of AKI. So for practical purposes, you can just remember one thing. Urea increases more in pre-renal AKI, creatinine increases more in intrinsic renal AKI. Just take this dictum in your mind. Urea higher in pre-renal, creatinine higher in intrinsic renal. Good. Now renal failure index is a ratio of ratios. Ratio of ratios, urinary sodium by urinary creatinine by serum creatinine. Now just see on your left, the numerator is less than 20 by denominator is more than 40. Just see, it is basically 2 by 4. So less than 20 divided by more than 40 will definitely be a number less than 1. And on your right, the numerator is more than 40, the denominator is less than 20, the ratio will be more than 1. As simple as that. Simple applied mathematics of class 5. Okay, no need to confuse yourself. No need to confuse yourself. Good. Next will be, what cast will you get in pre-renal AKI? You will get hyaline cast, and in intrinsic renal AKI, if it is an ATN, you will get what? Granular or muddy brown cast. You will get a granular or a muddy brown cast. I hope I'm absolutely clear. If I am talking about urine specific gravity, probably second day, the urine specific gravity, because in pre-renal AKI, the kidney will be hungry to reabsorb water, so there will be less of water, more of concentrated waste. So what will you get there? There will be hyperstenuria, and here in ATN, the kidney will lose its capacity to excrete waste, so there will be isostenuria. I hope you just remember what I taught you in the first class. Okay, nothing very difficult. Nothing very difficult. I hope I am absolutely clear to all of you. Last point of investigation of AKI, which is very important, that is novel biomarkers. First write down, then I will explain you what is it. What is it? Now, novel biomarkers are usually absent in pre-renal AKI, and they are usually present in intrinsic renal AKI. They are usually present in intrinsic renal AKI. So, novel biomarkers can be used to differentiate between pre-renal and intrinsic renal AKI if you haven't already done it. But usually it can be done otherwise only. Now, what are novel biomarkers is again a very important point, which I will make you write in details, because it is one of the most researched topics in nephrology currently. So this is a very trending topic in nephrology seminars, in nephrology CMEs, everywhere. Okay. So very important. This novel biomarker is very important, and every day new information is evolving. So even I don't know everything which is there about novel biomarkers. Every day new things are coming. So why are novel biomarkers used? Where are they used? They are used to diagnose or predict AKI in the initiation phase, when serum urea creatinine have not increased. So basically I told you in the very first point, and the very first phase of AKI was initiation phase. So I told you initiation phase is a phase that can last from 0 to 2 days. It can last for hours also, where the injury has already started to happen, but you have not understood that injuries happened. Why? Because patient does not show much thing, and the traditional markers that we have, urea and creatinine, they have not risen yet. If they have not risen yet, how will we understand that AKI has happened? We have reached the moon, but are we so dumb enough that we will not be able to diagnose AKI? No, we are not. So to diagnose AKI in the initiation phase, where urea creatinine have not risen, we use novel biomarkers. And what are the novel biomarkers is a $1 million question. They are number 1. Please write down what are the novel biomarkers. They are cystatin C. Number 2, let me give you the chart itself. Now, see, this is a very, very nice, I got this photograph from the web, actually a CME. So just see how multiple time zone how the organ damage are reflected in multiple time zones. Just see, the molecular is the first to ring the bell, because 10 baje hi it understood that something is wrong in my kidney. At 10 a.m. only it understood. But the cellular level took 1 hour more to reflect it. उसको 11 बजे समझ आया. उसकी दिमाग की बत्ती, after having a Mentos, it understood that 11 a.m. that something has happened. Biomarkers understood at 12 noon. But the clinical presentation and traditional markers, they understood even further. So this is how things progress. First things occur at a molecular level, then cellular level, then biomarker, and then clinical. If I can just relate to a subject known as PSM, I had read in the beautiful book called K. Park, which I used to not like earlier on, but I think it is of huge importance to public health. I think that one chapter was there on a screening test. You remember screening test? It gives you a lead time before a diagnostic test. That kind of a test is here, your novel biomarker. So before the injury has happened, you can understand whether your patient will have AKI or not. Is it clear? And these are the novel biomarkers. Please write down the names of these. Please write down the names of this quickly in 2 minutes. Basically what you will require is these. If you don't want to write the full forms, you can only write these, because in your exam you will understand what is what. So the novel biomarkers are cystatin C, NGAL, interleukin 18, KIM1, LFAP, and TIMP2. These are the novel biomarkers, and please write down all the 7 biomarkers. All the 7 biomarkers. Okay? I want you to have an edge. Though Harrison only has 2 or 3, but I do not want you to lag behind, because already institutes have targeted this topic and started asking questions. This is so important. AIMS has already, somebody has drawn the clock also. Very good. Bahut badhiya. Okay. So this is already being asked by AIMS, and they are asking tough questions. Okay. So just write down NGAL, which is neutrophil gelatinase associated lipocalin, interleukin 18, KIM1, L liver type fatty acid binding protein, IGF BP7, and tissue inhibitor of metalloproteinase 2. These are the novel biomarkers. I hope I am absolutely clear. Out of this, cystatin C and NGAL, out of this, cystatin C and NGAL are detected in serum and urine, whereas interleukin 18, KIM1, LFAP, IGF-BP7 and TIMP2 are detected only in urine. Only in urine. So these are the novel biomarkers. The first 2, full form not required, just the short form will do. You will ultimately understand what is it. Okay? So the first 2 are detected both in serum and urine, and the last 5 are detected only in urine. Only in urine. Is it clear? And let me tell you one very important new thing, though has not been asked, but let me tell you, out of these 7 biomarkers, only a combination of 6 and 7, 6 plus 7 have been approved by US FDA. US FDA. So out of these 7, only the last 2, that is IGF, BP7 and TIM2, we do a combination of both of them together. These 2 are together approved by US FDA. So rest are still yet to be approved. They are only used for investigational or research purposes. Only used for investigational or research purposes. I hope I am absolutely clear. If the patient is asymptomatic, why will you go for, if you have a hint that they can go into AKI? Okay? Is it clear? That is on the clinical judgment. Totally on the clinical judgment. Is it clear? Good. So these are the novel biomarkers. These are the novel biomarkers. Okay? And we have completed the investigation of AKI. Only the one thing is left, that is FENA. So you are asking me, sir, what is FENA? Detergent to nahi hai. What is it, sir? What is FENA? FENA is basically a mathematical equation. It is urinary sodium by serum sodium divided by urinary creatinine by serum creatinine. It is a measure of basically what I meant by nocturnal pain is, basically nocturnal pain rules out mechanical low back pain. So immediately, if a patient comes to you in OPD, in a busy orthopedic OPD, at least in one day, 100 patients will come with low back pain. So with every low back pain, you will examine everything, you will do an SLR, LASIK test and take the history. No, you ask some red flag questions. So one of which is, if he says nocturnal back pain, you understand it's not a mechanical back pain. You cannot discharge him with a NSAID or a paracetamol and send him home. So nocturnal back pain is a pathology. So probably the patient has had a fracture due to multiple myeloma. Is it clear? Is it clear? Good. Due to excess osteoclastic resorption and lesions in the bone, in the myeloma, the patient has had a fracture. Good. So this is FENA, and it is less than 1 in pre-renal, more than 2 in intrinsic renal. Now, what is the FENA in ATN? This has been asked 5 times, at least 5 times in the last 10 years. So I think you will not have any doubts regarding what is the answer. Answer is more than 2%. More than 2%. Okay? Okay? Very good. Very good. And now let us go to the treatment part of AKI. Let us go to the treatment part of AKI. But before that, I would just like to, for my interest sake and for a very important point, I will just tell you a point known as, I will just tell you a thing that is known as non-oliguric AKI. Now, if I were of your age and if I were of, of your standard, I would have felt this statement is an oxymoron. You know what's an oxymoron? Oxymoron is basically two contrasting words together. So, I felt that kidney ka kaam hai urine banana, to produce urine. And when I say kidney is injured, I know urine will not be produced, not be excreted out. So there will definitely be oliguria. But how can there be a condition where there is kidney injury also and where there is oliguria and there is no oliguria also? I absolutely did not know this condition, but I came to know about this condition when I saw practically the second patient of my medicine residency. And let me tell you what was it, and let me tell you exactly how I saw the patient. So I was a new medicine PG resident, like most of you are going to be in a few months or in a short span of time. And I was very enthusiastic. I reached the ward at 7 a.m. I took the over from my senior and everything, and I got to know what is it. And a patient got admitted. Actually, before I joined only, a patient got admitted with weakness of lower limbs and slight of the upper limbs, more of the lower than the upper limbs. And of course, seeing that, first of all, I thought, what? It's probably a demyelinating disease, probably a GB syndrome or a acute inflammatory demyelinating polyneuropathy. Now, when I got the tests, when the first I saw the background test that the patient had come up with, I saw that the patient had hypokalemia. The patient was having hypokalemia. The patient's potassium was around 2.2 or 2.3, and when we corrected the potassium with IV KCl, the patient's improved. So basically, it was basically a hypokalemic weakness. You know, hypokalemia causes flaccid weakness. So I understood that weakness was due to this. Now, when I told the patient, show me the entire reports, I saw the report with potassium and the creatinine was, to my surprise, 6.1. And then the patient was a farmer, and then I started taking history from the farmer. And then I said, sir, आपको यूरिन कितना हो रहा है? I have to talk in Hindi because this is what I asked. आपको यूरिन कितना हो रहा है? And in my mind I knew the answer. What answer did I know? High creatinine, kidney failure. I knew he would say, so urine aa nahi raha hai. But to my surprise, this farmer told me that, sir, urine is normal, sir. Sir, I'm going to the washroom for 6 to 7 times a day, and each time I'm having 150 ml urine. So I'm having more than 1 liter of urine. It absolutely shook me. What the fish? How can this person have so much of urine despite having so much of creatinine? So, next I thought, what to do? I took more history from the patient. I told, please tell me right from the beginning what happened to you. Then he started saying, sir, actually the story begins 10 days back when I was having a lot of loose motion, sir. Sir, I was having loose motions like 20-30 times a day, sir. I was not stopping only, sir. I felt like I have to sit in the washroom only, sir. So, sir, मैं ना सर अपने गांव के सबसे बड़े डॉक्टर बाबू के पास गया. I went to the biggest, most qualified person of my village, who was basically a quack, sir. And sir, quack क्या डॉक्टर थे, sir? वो quack what doctor he was, sir? He just felt my pulse, sir, and he diagnosed me. And sir, he gave me 2 injections in my bum daily, sir, for 7 days, sir. And what injection he gave me, sir? After giving 3 to 4 injections only, sir, my loose stool stopped like as if he had stop button, sir. I said, Acha, why? Then why did you land up here? Sir, he was very good, sir. He treated me also, sir. But sir, हुआ क्या? ठीक तो मेरा lose motion हो गया. But after my loose motion became okay, few days later, I started feeling weakness, sir. I started feeling weakness, I started feeling nausea, I started feeling, sense of vomiting, and my, legs became weak. So he said, कुछ फालतू टेस्ट करा लो, blood test वगैरह. He told me, the great doctor. So I got this test done. And sir, when I got the test done, when I went to him, when he saw the reports, sir, his face was not that happy, sir. And he told me that जाओ शहर जाके किसी कम qualified person, कोई MD या कोई DM को दिखा लो. He basically told me, go and visit a less qualified person like an MD or a DM doctor को दिखा लो. But sir, what doctor he was? He went on praising him. I understood. Oh, acha, that is why you have come to less qualified people like us. He said, yeah. I was like, okay. So then I was really perplexed because I was not as smart as you. I could not understand everything. So I went back to the library, took out a nephrology book, took out medicine book. First of all, I thought, what is this condition where there is kidney injury but the urine output has not decreased? So I came across this term, non-oliguric AKI, and there was this term non-oliguric AKI, and I had understood retrospectively after reading the cause of non-oliguric AKI that what could have the great quack prescribed to my poor little farmer. And I hope you have understood what the patient was prescribed, and the patient was prescribed number 1, aminoglycoside injections. He was given a lot of streptomycin or amikacin injections in his bump daily at a very high dosage, because of course the quacks don't care about the dosage, they are too supremely talented. And so this was basically aminoglycoside toxicity. And if you remember, after aminoglycoside toxicity, what had happened? The patient basically developed a ATN-like condition. Patient basically developed ATN-like condition, which develops 5 to 7 days after drugs. 5 to 7 days after having given the drug, the patient develops aminoglycoside toxicity and the patient develops ATN, which mainly involves the proximal convoluted tubule, and the patient classically presents with hypokalemia, hypomagnesemia and hypocalcemia. And this was the reason why my patient had a flaccid quadriparesis. So basically it was an aminoglycoside toxicity which the patient developed, and this was the reason. And this is an MCQ. The MCQ is aminoglycoside toxicity develops how many days later and what are the manifestations, and it has a non-oliguric AKI. All these are MCQ points. All these are MCQ points. Is it clear? Absolutely clear. Very good. Next is, I told you, one of the exogenous contrast that you can give, exogenous toxin that you can give a patient is contrast, and the contrast can develop contrast induced nephropathy, which is known as CIN, contrast induced nephropathy, which is known as CIN, and which is basically, it is a true incident. It is a true incident. Contrast induced nephropathy, and that develops after exposure to iodinated contrast and high osmolar contrast. Clear? And high osmolar contrast. Now the particular clinical picture of contrast nephropathy is, the serum creatinine begins to rise, peaks and normalizes. So it basically follows a typical graph. It begins to rise in 1 to 2 days, peaks in 3 to 5 days, and normalizes after 7 days. Is it clear? Absolutely clear. Contrast nephropathy, and how do you prevent contrast nephropathy? How do you prevent contrast nephropathy? Of course, you prevent contrast nephropathy by you prevent contrast nephropathy by, of course, not giving contrast in highly vulnerable patients, of course. But still, if it's a mandate you have to give, तब क्या करोगे? You will do number 1. The best thing is by hydration, and you give the patient isotonic saline. And sir, can you give something else? Also, one of the drugs that we do give is N-acetylcysteine. You must have heard N-acetylcysteine is a mucolytic found in many cough syrups. N-acetylcysteine is an antioxidant. In fact, it is one of the molecules which is under a lot of research now. And N-acetylcysteine is a nephroprotective drug also. The exact mechanism not known, but it is seen to protect the kidney function also, and it is used to prevent contrast nephropathy also. I hope I am absolutely clear. So the two causes of non-oliguric AKI that I wanted to impress upon you are aminoglycoside toxicity, contrast-induced nephropathy, and these two. I hope I am absolutely clear. Okay? So, last thing, how do you treat AKI, and then we can go for chutti. The last thing is treatment of AKI. The treatment of AKI is basically supportive treatment. That is number one, treat the cause. तो सर अगर डायरिया है तो डायरिया को ट्रीट करो, अगर रोड ट्रैफिक एक्सीडेंट है तो रोड ट्रैफिक एक्सीडेंट को ट्रीट करो, इफ देयर इज अ स्नेक बाइट गिव एंटी स्नेक वेनम. सो बेसिकली जस्ट treat the cause. So you basically have to treat the cause. Number two, you have to maintain balance. That is, you have to maintain electrolyte balance. You have to maintain fluid balance. And you have to maintain acid-base balance. So what are the abnormalities in the electrolytes that you can develop? What are the abnormalities in the electrolytes that you develop usually in AKI? The abnormalities are, you can develop a hyponatremia, a hyperkalemia, a hypermagnesemia, and a hyperphosphatemia. So mostly you develop all hyper but only one hypo. You develop all hyper but only one hypo, that is hyponatremia. So these are the electrolyte manifestations of acute kidney injury. Fluid, you can develop anything depending upon the cause. And acid-base balance में you usually develop metabolic acidosis, and of course you treat accordingly. Whatever you get, you treat accordingly. Clear? Absolutely clear. Next, the neglected part is nutrition. Trust me, this we are not taught properly in medical school. It is the most neglected part, and sir, the patients are interested the most to know this, sir, because patient will keep bugging you and will ask you the silliest of questions. Sir, Horlicks pee lu, sir, patient is very weak, sir, can I mix something in the milk and have, sir? Especially in government colleges, in government hospitals. I said, okay, pee lo. Sir, Horlicks pee lu. I was like, okay, pee lo. Sir, Bonvita bhi pee sakte hain kya? Can I have Bonvita also, sir? I'm like, dude, please have whatever you want to. Actually, they really ask because nutrition is very, very important, but we neglect this because we are focused more towards drugs and investigations. But this is very, very important. So what nutrition you will give to AKI? You will give both calories and you will give proteins. How much will you give? You usually give 0.8 to 1 gram per kg protein, and you give the patient 20 to 30 kilocalorie per kg. Okay? This is how you treat the patient. So you give calories and protein, and last but not the least, how do you treat the last armament in the hands of a nephrologist when everything fails? Actually, without this, a nephrologist is nothing. Let me tell you, without this, a nephrologist is very, very handicapped, and that is renal replacement therapy. That is renal replacement therapy, and that is abbreviated as RRT. And of course, what do you mean by RRT in a setting of an AKI? You basically mean dialysis. And I will teach you dialysis in CKD, but I will just tell you what modalities you can use to treat AKI by dialysis. The modalities are, number one, that you all know, hemodialysis. Next, peritoneal dialysis. And last but not the least, something known as CRRT, or continuous renal replacement therapy. CRRT, PD and HD. These are the three forms of dialysis that you can do to a patient of AKI. And please understand, out of this, HD and PD you will be taught in CKD only, but CRRT is done only in AKI. CRRT is done only in AKI. It is peritoneal dialysis. And I'm teaching you this because, number one, it is not written properly in your book, and number two, questions are being asked on CRRT. Do you want me to teach it? Yes. CRRT only in AKI. You just need to know one sentence. Sir, when will I do CRRT? Sir, कब करूँगा CRRT? एक तो this is not done in CKD. It is only done in AKI. And it is done in AKI when the typical setting will be what is the clinical setting? The clinical setting is seriously ill patient in ICU, hemodynamically unstable, on multiple inotropic support. This is the typical setting of a CRRT indication. So let me give you an example. A road traffic accident patient comes, just like I told you, has developed rhabdomyolysis, has developed AKI, has severe hypovolemic shock, has developed cardiogenic shock also. The patient's BP is 70/40. You put him on noradrenaline, patient is still maximum noradrenaline dose, patient BP is 90/60. Can you do an HD? Can you do an hemodialysis? No. Why? Because it rapidly shifts the blood out of the intravascular compartment, takes out of the body. So in that rapid shifting, patient will develop more hypotension and the patient can be transmitted vertically. So you cannot do so. You have to do something which is a very slow technique, very slow. It's a continuous process, not an intermittent process. So it will continue for 2 to 3 days, just like the background sitar, just like your kidney is functioning normally. So for that, you need a patient who is seriously ill, who is very hemodynamically unstable. So who's on multiple inotropic support. So you gave NORAD, did not work. You added adrenaline, still did not work. You added vasopressin to the patient. Now also not working. BP is now just 120, 130. So this time kidneys are shut down. You have to do a dialysis. What will you do? You cannot do an HD or a PD. PD can still be done. But PD again, you require a lot of monitoring. And you require a person who has to sit by the side and perform PD exchanges. So what will you do? You have to do CRRT, which is a continuous process. Like, you know, in an orchestra, there's in the classical orchestra, what you have, there's a background sitar which is playing, and on top of that numerous instruments are playing. So CRRT is that. It will function like a physiological kidney and will keep filtering the waste in the background in a small, slow, sustained fashion. I hope I am absolutely clear to all of you. You are correct. CRRT is not available everywhere. It is available only in tertiary care setups, that too very limited, and it is quite expensive also. Is it clear? Absolutely clear? Very good. With this, we complete today's class. Some of you are very irritated. You can please go and have your dinner. You are very hungry, I can understand. Lot of hormones are calling you. Please go. And those who are interested, do you want to discuss some questions? Please give me a love wala smiley. Please give me a love wala smiley. We have discussed this. We have discussed this. We have discussed this. Now, Ames question. Ames question. This is again an Ames question. Though not my topic, but since I discussed it, let me teach you Ames 2017. Tumor lysis syndrome does not have. It has hyperkalemia, yes. It has hyperphosphatemia, yes. Hyperuricemia, yes. Hypercalcemia, no. It has hypocalcemia. So answer is tumor lysis syndrome. Tumor lysis syndrome. Now, let me see who can answer this. Let me see who can answer this. Sir, amphotericin B, you made us write in the pre-renal cause of AKI by causing intrarenal vasoconstriction. Do you remember? It causes intrarenal vasoconstriction. It causes pre-renal AKI. And sir, it can cause toxicity to PCT epithelium also. It can cause toxicity to PCT epithelium also, and it can cause ATN. Do you remember the take-home message I told you? That ATN is caused by AMP-B and aminoglycoside and is not caused by, and they don't cause AIN. So answer is both. So if I ask you, tell me two drugs which cause both pre-renal AKI and renal AKI. Quickly tell me. Sir, one is amphotericin B, you told me, and anything else I told you? Sir, NSAID, sir. NSAID can cause pre-renal AKI by constricting the afferent arteriole, decreasing the blood supply. And sir, NSAID can cause AIN, sir. Very good, sir. Acha, let me tell you, let me see who answers this. Metabolic abnormalities in AKI include all except hyperkalemia hoga, hyperphosphatemia hoga, hypermagnesemia can there, hypernatremia no sir. You will have hyponatremia. You will usually have hyponatremia. So answer is hyponatremia. Let me see who answers this question for me. Let me see who answers this question for me. Which statement is true about ATN? ATN occurs mostly in outpatient patients, usually on an NSAID. No sir, NSAID to mostly develop AIN, not ATN. And sir, not in outpatient patients. It usually develops in IPD patients or ICU patients. Those who are admitted, sir, because those who are more critically ill. RBC caste are present in ATN. No sir, it is the granular caste or muddy brown caste. In ATN, sir, urine is concentrated with a osmolality of more than 500. Sir, in ATN, urine will be less concentrated, sir, because there will be more of water, sir, because there is a reabsorptive defect. So, in pre-renal AKI, where the RAS is activated, there is excessive reabsorption of water, so urine will be more concentrated, having less of water. So in pre-renal AKI, the osmolality is more than 500, and in intrinsic renal, it is less than 350 milliosmoles per kg, and of course ATN is intrinsic renal. So answer here is sodium reabsorption is reduced, leading to high FeNA. Yes, FeNA hoga. Answer is 3. FeNA is more than 2%. I told you. Now this was a beautiful question. I have to appreciate this beautiful question because I really appreciate this is an Ames question, and I think this is a wonderful question, and everybody will not be able to answer it. I know my students will be answering it. all are markers of AKI except, just see, early, abhi tak they were just asking you which is the novel biomarker. They have gone one way ahead. Sir, you have to know which is a novel biomarker, which is detected where? Urine NGAL, plasma NGAL, urinary interleukin 18, plasma interleukin 18. Just see the beauty. I told you, two things are detected in serum and urine both. One is NGAL and cystatin C. So urine NGAL, yes. Plasma NGAL, yes. But interleukin 18 is detected only in serum. Only in serum. So answer, only in urine. So answer is plasma interleukin 18. Answer is plasma because it is only detected in urine. With this, I conclude today's class again by remembering my hero Muhammad Ali, who said, I hate every minute of training. But I said, don't quit. Suffer now and live the rest of the life as a champion. I totally agree to him on everything, but I will tell you, do not hate even your training. Enjoy it. If you enjoy it, you will love it and you will do it in a very good pace. And you will succeed in it for sure. Things you enjoy, nobody can stop you from succeeding. And if you work hard, these 6 months will take you very far off in life. Because so much is there at stake. I know I have pushed your limits, again held you back for more 18 minutes. But I can't help it. I want to finish more and more, give you more concepts and spread the love of medicine, spread the love of nephrology. And I want the community of internal medicine to grow stronger. And all of us will collaborate and learn together. I really thank you from the bottom of my heart. And I plead you to please, I request you all to please join my Facebook page. I know all of you are on DAMS Club. This is my page, which is known as Love for Medicine. You can please join this. I give almost very frequently interesting updates, photos, videos. You got anything related to medicine, please join this. And this is my YouTube channel, which I have opened recently. I want to give more and more videos to you also, which will be available both on the Facebook Club and elsewhere also. Okay, so thank you very, very much, and I am with you all. I hope you enjoyed. Please, and the question I asked you regarding plasma cell, I want it in my comment box. Thank you.